Welcome to this discussion on the Agora. How can we be more innovative in the way we deliver health education? My name is Ziad Limam. I'm a French-Tunisian editor. I live in Paris. And my guest, starting from next to me, Dr. Wing Chang from Behavioral Sciences from the RAND Corporation, representing the World Innovation Summit for Education. Dr. Anis Brick is in Doha, Director of Family Policy, Doha International Family Institute within the Qatar Foundation. And Dr. Walid Khoronfleh, Director of Research and Policy, World Innovation Summit for Health. Let me start with a main basic question for us non-knowledgeable people on the issue. What is exactly health education? What are we talking? Are we just talking prevention, or is it something much larger than that? Please.
Thank you so much for having me here. So I think when we talk about health education, we need to think of a larger framework of health and education as part of well-being. So when we think about well-being, wellness, education, and healthy mental and physical health are part of the well-being for children and adolescents. So when you combine the two together, thinking about health education, that will go beyond just physical health and addressing mental health, addressing happiness, addressing social relationship between peers and with family and in the community as well. So when we take a step back and think about health and education that way, then the context in which health education can be delivered is beyond the school ground. We can think about health education being delivered in the community, health education involving family. So I think within that framework, then health education is much broader than physical education or nutrition. It's really about how do we help young people to become successful and healthy and contributing citizens to our community.
Dr. Brick?
I think she provided a very good answer. For us, from the family perspective, we believe that health education should be much more broader, not focus on the patient only. Should include all the family members, the society, the community. You said prevention, yes, of course, is prevention and recovery. The main outcome, or at least the first goal, is to improve patient outcomes and the community well-being in community and the society well-being.
Thank you for your framework. I mean, certainly that's a very important framework, and thank you for also reflecting that on society. What I would like to sort of present is that the link between education and health is complex in nature, but at the same time, it's a reflection about the well-being of the person and the well-being of the family and the well-being of a society. So we do know that people who are better educated, they take better care of their health. We do know that people that are better educated, they have better resources. We do know that people that are better educated, they have higher income. So you can see the complexity of this matter. That's number one. But it also reflects on the knowledge, the skills and behaviors, within the family and within the society, to the point where it can create what's called nowadays healthier neighborhood. So people that live in a community, in a subdivision, that have a certain kind of a standard living, then that affects their health, that affects their behavior, that affects the society in general. So we're going to start with this larger framework, but we can sort of discuss other things as well.
How can we adapt this concept of health education through family, communities, etc., according to different types of words? I mean, we're talking rich word, we're talking developing word, emerging word. Is this the same concept, or should we adapt it totally depending on where we are in terms of revenues, GDP, level of development?
Yeah. So this is an excellent question, because many times what you see is things are culturally driven, and where our quote-unquote business norms in one society, it might be different in another society. And even sometimes within a country, you will find sort of pockets of culture and behavior that's very, very different, and even among immigrants and migrant workers and so forth. So certainly certainly there needs to be an adaptation of the understanding of education in health and how you inculcate that in K-12 and beyond. And then you have to talk about intervention, but you have to talk about intervention at the school level. You have to talk about intervention for workers in the work environment. You have to talk about intervention at the societal level. So it's not the same. It's not one size fits all.
I mean, as you know, there are some context differences, but there are many common trends. As you know, the family are untapped resources for the support of family for health system. As you know, most of the healthcare system around the world are provider-centered and not patient and family-centered. This is a common trend. We see at our organization the need for engaging families, involving patients and family members in all decisions, healthcare decision, and education. I can share the example of one innovative initiative in India called Nora Health. What they did is transformed patient family members into equipped caregiver by providing them training, providing them basic skills, by educating them to use those skills at home after the recovery. So as I said, yes, it is important to consider the culture and the context, but from our perspective, there is a common trend of the lack of engaging family and patient, and there is an important need for changing the narrative or changing the system into a holistic approach of health education, which involve providers, all families, patients, and all the stakeholders.
Dr. Chan, on the question on who is delivering this health education, who is entitled to take decision about what is the topic which has to be approved and delivered, which orientation we should take? Is it state, government, association, communities? How do you see that?
I think it does have to involve all levels. So we're talking about national policy setting the framework, how health education and how health and education are related. But then when it comes to implementation, we have to think about local involvement and cultural adaptation. And one thing I want to point out is that we also have to involve the voice of the young people, right? We're talking about delivering health education to young people. Oftentimes, they're not always very actively involved in the process of developing the curriculum or the practices. So I do think in addition to community members, teachers, principals, and family members, the voice of the young people is definitely needed. And through the process of involvement, they learn a lot of skills that are going to be really important in terms of their long-term health and educational pursuit as well.
On this issue, on who's delivering content, who's deciding on content, what's important, what's not important?
For us, it is very important and vital to involve all the family and the patient in the content. As I said, most of the modern system now are provider center, and based on the assumption that patient will do better when they comply with the provider knowledge and the provider recommendation. I think it's very important to also to involve the other members, the patient themselves, their family members. Recently, we published a report on the pediatric psychosocial in Qatar, and the result shows clearly that in terms of content, in terms of the information shared in the context of Qatar, there is an important need for coordination, for the transparent communication, for sharing those knowledge between the families, family members, the patient, and the medical staff. Yeah.
So I'm going to answer this question a bit differently because I come also from a policy perspective. So I know at the end of the day, Ministry of Finance is the one that writes the check, okay? So there has to be evidence-based outcome. And without that, it's very difficult then to justify the investment, particularly when you have multiple stakeholders and sort of multiple issues. But what really helps if you have a national plan or a strategy, because it serves as a framework and a driver for this particular issue. For example, recently, about almost a year ago, there has been a launch of the National Strategy for Autism here. And that has presented a springboard in order to engage people. So I've jotted like a few things in terms of principles, because, I mean, you said, okay, what's going to drive this? So content, of course, extremely important, and she talks about the engagement. But let me just share with you couple of these points. So we talk about access and inclusion. You have to be inclusive, right? I mean, with all your stakeholders and partners. You have to focus on outcome, being evidence-based, but it's important to have a holistic approach. All right? Without a holistic approach, then it's very difficult to drive the agenda. And you have to engage the families. And without the engagement of the families, and I think one of our partners here is Children's National Hospital, and they, in one of their autism centers, they have engaged the families through either workshops or through sort of pamphlets and brochures and stuff like this. And cultural competence, I go back and say that it's not one cookie cutter at all.
You talked about financing, which is probably one of the major issues, whether in the rich world, on the poor area of the world. But I'd like to finish our discussion before we move to our guest about how can we adapt health education to global issues, 21st century global issues. I think, for example, as environment and climate change, which are part of our well-being. But I also think about reproductive issues and demographics and population. Can we try to input in the curriculum, global curriculum, those issues which are really crucial for our future?
I can give you one quick example, maybe from my U.S. background. I mean, if some of you that perhaps remember that Everett C. Coops, general surgeon, said that smoking can cause cancer. But it really, to see the effect of that, it took almost 20 years, right? It was inculcated into a K-12 curriculum. And then over the years, you say no smoking in cinemas, no smoking in restaurants, no smoking in malls, and so forth. So yes, it's a journey, and it has to be over time, and it has to be inculcated into curriculum and national campaigns for the society. But that's a very excellent point.
On this issue?
I think one important driver is the information technology. Technology, I think, and is doing now and impacting the way we perceive or communicate or all the health issues across the world. I mean, we see here, and there are many companies here doing great stuff, from apps, sharing information, raising awareness, educating people, educating patient families, and the whole society about many issues. I think technology would be and is one of the driver
of that change.
Yes.
Dr. Wang, could you maybe conclude?
Sure. Just really quick, I think one of the ways we can think about health education to address global challenges now is really trying to break the disciplinary barriers even between K to 12, not just talk about math and then literacy, arts, but really think about how do we deliver well-being in all the subject areas that are being currently implemented and delivered to all the children and adolescents. And lastly, I think we have science and evidence to suggest that people learn differently, so we have to be creative in terms of how do we deliver lessons plan. Oftentimes, young people learn better when they're hands-on, when they're able to really do experiment and experiential learning. So I think with all these different innovations in education, there are definitely multiple ways through which we can deliver 21st century ready health education.
Thank you all. We'll turn to the room. Some ground rules. We have about 8 to 10 minutes. So very short questions, and please introduce yourself so they'll know who. Please, gentlemen.
Hello, I am Dr. Shamim Al Mamun from Ministry of Health and Family Welfare from Bangladesh. Thank you for all for here being. Just a simple question. If there have a innovative something in the healthcare delivery system, health education delivery system, there is have any global strategy. This is required, a global strategy. If I think if there is have a global strategy, then the country, any other country can take the strategic framework from here. In country perspective, they can build up their national strategy. Is it necessary? Thank you.
That's a very good question, global versus local. But some of the fundamental issues and the people that require education and education in healthcare are actually in rural areas. So if you talk about places in Central Asia, you're talking about places in the Indian subcontinent, that's going to present a challenge. You have to bring the technology there, and you probably have to do it not at an individual level, but at a sort of community level. And there are some companies and NGOs that are doing that actually in terms of sort of educating the communities about some of those issues. So technology is great, but if you don't have access to it, you know, it's a challenge. Not everybody has an iPhone and an app.
Actually, there is a session tomorrow about remote areas and health.
Yeah.
So we can discuss about that. Please. This way.
Yeah, hi, good afternoon. Thank you. Jim Campbell from the World Health Organization. I want to pick up on the question about who is delivering health education and who is designing health education and get the perspectives. We heard lots of constituencies mentioned. Families, communities, adolescents, youth, facilities. We didn't hear mention of any health workers who are the conduit for health education. So what's the perspective and what are you doing around engaging with health workers to deliver public health, primary health care messaging? Secondly, clearly around the world today, we also have a number of governments that limit what can be in the messaging on health education. We don't have to name names, but if we talk about sexual and reproductive health, some governments will be very specific on what can be taught, et cetera, et cetera. What's the perspective there?
First question, and maybe...
Certainly, health workers are a pillar and central to the issue of health education. And as a matter of fact, what you see that in many Ministry of Educations and schools, there will always be either a social worker or a nurse that's part of the system that's on site. Now, the curriculum needs to be developed and needs to be culturally sensitive. And you pointed out to one important issue in terms of sexual reproduction. In some countries, maybe it's an open sort of issue that can be discussed openly, but in other countries, probably not. It needs to be sort of delivered in a very sort of sensitive way. So designing the curriculum and the way you present it, I think it has to involve social workers, it has to involve healthcare workers, and have to involve educators.
On the ideological issues,
I would like to...
Please, feel
because
free.
he mentioned the importance of workers, and I'll talk about the report we did and the issue of pediatric psychosocial in Qatar. And one of the challenge we face is the shortage of a quality life specialist. And the sector 2 years ago was not organized in Qatar, and still there is huge shortage of this type of expertise. Recently, the Ministry of Public Health organized the sector by providing or developing guidelines to certify those important components in healthcare. My second example was in India, and the initiative was a response to the lack and shortage of medical staff in India. So because of that shortage and lack of human resources in healthcare settings, doctors and hospitals start targeting the family, or let's say engaging the families to play another role which is supposed to be by the medical staff. I think medical staff or health in general, human resources are extremely important, but we have to acknowledge the difference in different contexts, the difference in terms of institution, in terms of resources and quality of resources, and sometimes lack of regulation or lack of a framework to organize those kind of human resources.
Just a word, and maybe Dr. Chen, a word about those ideological policy difference between states and culture. How can we overcome that? May we arrive to some sort of a global minimum in health education? The gentleman was talking about, states making decision about reproductive health or any other issue that they seem sensible or difficult.
Yeah. One way that I think we could possibly think about is the utilization of community health workers. Using them has been very successful in immigrant communities in the U.S. and globally because they're from the community. They have the cultural knowledge how to deliver these messages, and also they are also part of the community, so they're trusted community members. So that's one of the ways we can think about delivering culturally sensitive health education. Another thing that just came to mind is the concept of task shifting. So if there is a lack of health workers or health educators, perhaps we can train teachers and other staff member and personnel at school to do the task shifting so that they can also deliver health education. So those are just two ways that just kind of came to my head right now.
Questions? The lady there.
Hello, thank you very much for great panel discussion. My name is Aziza, and I'm the manager of Health Promotion Department for here in Sidra Medicine. And I have a team of health promoters. And we develop very culturally sensitive health education programs, both for our patients but for the community as well. And one of the things we struggle with is, you've all pointed to the importance of engaging the family. But one of the things we struggle with is the uptake of the programs that we actually do create. Sometimes we have up to, 50% no-show rates. And so the idea of community health workers is not existing to my knowledge here in Qatar, where I come from in Canada. That was one thing we used. But how do we go to, what are some innovative ways, particularly from the representatives here in Qatar, that we could increase the uptake of what we have developed?
This might sound like heresy a little bit, but I think many times in the way we promote health and education, the way we approach it, we are in a sort of ivory towers. We are on a pedestal, and we need to present the material in a non-technical way. We need to present the material to a layman person, sort of approximate the ideas, the thoughts, the impact. I think sometimes we just teach them, we look at them as if they are the students and we are the teachers, and we are there to impress them, not really to educate them and engage them. Really, my daughter was diabetic, and in the U.S. I went to some of the classes. I was just like, okay, I'm a doctor, but they were talking to me as if I'm like, they know and I don't know. And so you imagine you can multiply that in terms of sort of the cultural issues that comes with that. You're there to help and educate, and helping and educating doesn't mean you have to show off. Sorry, but, we need to change our approach.
You mentioned the somehow lack of family engagement. And we studied this in our center. And, there are many causes. First, there's a lack of awareness from the family. And also, but there is no time. There is no policies for leave policies. If you talk with hospitals, there is no space.
please finish.
But also, some family are willing to engage, are willing to be involved. But even hospitals, there is no space to meet the families. Doctors, they don't have the time to have the families. They don't have sometimes the skills. And so we can't blame the family or doctors. So if you want a holistic approach of healthcare engaging the family, first you have to educate, raise awareness of families, create policies, develop new policies, leave policy for healthcare, for caregiver, creating facilities inside hospital and clinics to accommodate meetings, create system where families and healthcare share information, communicate, and so on. So I think there is a lot of thing to do. It's not easy to say, well, I mean, of course, if I have no time to go to hospital, and if there is no space there, obviously it would be very difficult to engage families.
Thank you very much. I think we've been called to order by the speaker. I think we can applaud these gentlemen, ladies and gentlemen, for this very rich discussion. And you can keep engaging with them on the coffee tables, whatever, around the WISH Forum. Thank you very much.